Hello, everybody. This is part 2 of our lecture about echocardiographic assessment in coronary artery disease. We will talk about the role of echocardiography in chronic coronary syndrome and stress echocardiography with multiple demonstrative clinical cases. Echocardiography is useful for a range of indications, including diagnosis, risk stratification, and clinical management decisions. Chronic ischemic heart disease often results in impaired systolic left ventricular function. The extent and the severity of regional and global abnormalities are important considerations in choosing appropriate medical or surgical therapy. Abnormal left ventricular diastolic function frequently accompanies impaired systolic function, but also may be the only abnormality while resting global and regional function are normal. This is a list of structural and functional alterations that can complicate chronic ischemic heart disease. First, left ventricular scar and aneurysm. A transmural effort will result in a myocardial scar seen on echo as akinetic or dyskinetic segment with thinning and increased echo reflectivity. An aneurysm is a discrete outpouching of the ventricle with preservation of all three heart layers. They tend to develop at either the basal inferior wall or at the left ventricular apex. The outpouching may be relatively shallow, and the flow by color Doppler tend to be laminar and non-turbulent. Flow within an aneurysm is frequently sluggish, as evidenced as spontaneous echo contrast, which can be more prominent if the patient is not anticoagulated. This will predispose to formation of left ventricular thrombus. The presence of extensive myocardial scarring, which conducts electrical impulses poorly, can also pave the way for re-entrant arrhythmias such as ventricular tachycardias. VTAC, due to scars, tend to be monomorphic, have sudden onset, and can cause symptoms that range from palpitation to sudden loss of consciousness or even sudden cardiac death. Another consequence of chronic ischemic heart disease is left ventricular thrombus. Forward thrombus may be detected in left ventricle within 24 hours after MI, and the most are often formed within the first 1 to 2 weeks after MI. Patients with large anterior MI, left ventricular ejection fraction less than 40%, and the severe akinesis or dyskinesis are at high risk of left ventricular thrombus. Thrombi appear as discrete, homogeneously echogenic, deformable masses abutting the endocardial border, invariably next to an akinetic or dyskinetic segment. Although the specificity of transthoracic echo for detection of thrombus is good, generally above 90%, but the sensitivity range only from 30 to 60%. In routine echocardiograms performed without contrast, this is in comparison to delayed gadolinium enhancement with cardiac MRI. Is a case demonstration of left ventricular mural thrombus. 40 years old male patient, chronic heavy smoker, recurrent ongoing chest pain for 48 hours, presented with missed extensive anterior STEMI. Here you can appreciate the long axis and short axis. We can appreciate akinesia of the anterior septum. This is the apical 4 and 2 chamber views. We can here appreciate the akinetic septum and the akinesia of the apical segments involving the apical inferior and the apical anterior. But we can't visualize the apex properly in this view or in this acquisition. The apical long, the infraradial wall is contracting well, while the anterior septum is akinetic. Here is mitral regurg. So the patient has akinetic mid-anterior septum and akinetic apex and all adjoining apical segments. However, the apex is obscured and is not visualized clearly. Here, with proper acquisition of the apical window, avoiding foreshortening, we can appreciate this mural thrombus. It's clear, related to the akinetic segment, echogenic, and can be differentiated from the left ventricular wall. Left ventricular remodeling or ischemic cardiomyopathy. After myocardial infarction, the left ventricle as a whole can begin to expand in size and mass in a process termed ventricular remodeling. Concomitant changes in both geometry and function of the left ventricle frequently accompany remodeling. From a hemodynamic standpoint, those changes may initially help increase cardiac output, but in time they can have negative consequences. On echocardiography, left ventricular diameters and volumes will increase if the left ventricular wall thickness remains the same or increase. Overall left ventricular mass will increase. This is called hypertrophy. Ratio termed relative wall thickness in combination with the total left ventricular mass to characterize the type of hypertrophy. Relative wall thickness is the sum of the diastolic wall thickness of the interventricular septum and the diastolic wall thickness of the posterior wall divided by the end-diastolic diameter as shown, demonstrated in this diagram. Here we can appreciate the relative wall thickness in relation to the left ventricular mass. Normal left ventricular mass index to body surface area for females is less than or equal 95 gram per meter square, while for males, adult males, 115 gram per meter square body surface area. Normally, relative wall thickness is less than or equal 0.42. If the left ventricular mass increased, this is called hypertrophy, and according to the relative wall thickness, if it is less than 0.42, this is called eccentric hypertrophy. If the relative wall thickness is more than 0.42, it is called concentric hypertrophy. Border zones adjacent to recent infarcted area can develop wall motion abnormalities, a process termed infarct expansion, but even areas relatively remote from the original infarct may become hypokinetic despite preserved epicardial coronary artery flow. The pathophysiology underlying these changes is complex, but is postulated to be initiated by increased myocardial load, which causes increased interstitial fibrosis and a further diminution in cardiomyocytes, which in turn decrease overall contractility and relaxation of the ventricle. With more extensive remodeling, the heart often becomes more globular in shape. The change in shape may be measured by sphericity index. This is sphericity index measured by the height and over the height divided by the width. The height we can height from longitudinal axis from the plane of the mitral annulus to the left ventricular apex. The width is measured at the basal part. Normally, the height divided by the width of this wrist index is usually 1.5, and in markedly remodeled heart after myocardial infarction, this ratio may decrease to approach 1, and this is the more the left ventricle becomes sphere in shape, this means extensive remodeling. Severely dilated ventricles often manifest with a combination of one or more of the following features, in addition to increased relative wall thickness and sphericity: very low ejection fraction, spontaneous echo contrast, dysynchrony, reduced aortic and mitral leaflet excursion, increased ventricular filling pressure. If the Doppler mitral flow pattern reveal evidence of restrictive physiology, this predicts a worse prognosis than earlier forms of diastolic dysfunction. Secondary mitral regurgitation. Functional or secondary mitral regurgitation is leakage of the valve that is essentially due to left ventricular systolic dysfunction and remodeling. When left ventricular dysfunction is due to coronary artery disease, it's termed ischemic mitral regurgitation. Unlike acute ischemic mitral regurg, which is caused by papillary muscle rupture and the flared leaflet, the functional ischemic mitral regurg, the mitral apparatus is structurally intact, but its geometry and balances between opening and closing forces are altered in a way that prevent effective closure. Many factors are known to contribute to functional mitral regurgitation: tethering of the mitral leaflets and the chordae, restricted leaflet mobility and closure, papillary muscle dysfunction and or fibrosis, papillary muscle displacement, annular dilatation from an enlarged left ventricle and left atrium. Reduced contractility of the left ventricle as a whole also means that the closing forces that contribute to pushing the mitral leaflets closed from behind. The sum of these changes, together with increased volume from the mitral regurgitation itself, which causes more chamber expansion and displacement of papillary muscle, appear to generate a cycle, so mitral regurg begets more mitral regurg. Inferior and infralateral infarction in particular are strongly associated with functional mitral regurgitation because the right coronary artery alone supplies the inframedial papillary muscle and the posterior leaflet. The effective regurgent orifice area is one key quantitative measurement of mitral malcoaptation, which has a direct correlation with mortality in ischemic cardiomyopathy. Effective regurgent orifice area is calculated from color spectral Doppler measurements and a value more than 0.2 centimeters square, and the regurgent volume more than 30 milli or regurgent fraction more than 50% is indicative of severe secondary mitral incompetence. The diagram showing the different mechanisms of secondary mitral regurgitation, from left ventricular dilatation and spherical remodeling, papillary muscle displacement, chordal tethering, restricted leaflet closure, mitral annular dilatation. Case number 6, 57 years old male patient, uncontrolled diabetes, history of stroke 2 years ago, experienced myocardial infarction 1 month before presentation, coronary angio was done and revealed multiple vessel disease, presented with decompensated heart failure for evaluation for surgical revascularization. Here's the parasternal long axis. Can appreciate here that the ventricle is dilated, the septum is preserved thickness. However, it seems it's not thickening well. It is moving rather than contracting. With mitral incompetence, it is central. Short axis at the level of the papillary muscle level. Here, at the apical level, and akinesia of most of the apical segments, but no evidence of mural thrombus. Apical four-chamber view, extensive akinesia of the apex, apical septum, and apical lateral wall, severe hypokinesia of the mid-anterolateral wall. Only the basal segments are contracting. Here is the mitral regurg. It seems that it is moderate mitral incompetence, occupying less than 30% of the left atrial area. Here the calculated vena contracta is 0.5, denoting a moderate mitral regurg. Here we can appreciate the significant tinting of the mitral valve leaflets. Let's draw an imaginary line at the level of the mitral annulus. Here is the tinting area. It's continuous wave Doppler, and we can appreciate here the density of the regurgitant jet is not severe, denoting moderate incompetence. However, the change in dPi over dt, our rate of change of left ventricular pressure, is markedly reduced, 592 millimeter mercury per second, denoting severe left ventricular systolic dysfunction. This measure, the mitral regurg dP and dt, is supposed to be load independent, so it's not affected by the severity of mitral regurg. Here is M mode as the tip of the mitral valve leaflets. You can appreciate here there is no significant restriction or no abnormality in the mitral valve leaflets, no prolapse, but the excursion is significantly reduced due to low cardiac output. With M mode on the left ventricle as a mid-papillary level, we can appreciate here that the septum is not thickening. It's just a translational or displacement movement. RV inflow view showing tricuspid incompetence. This is M mode showing TAPSE is 1.9, denoting normal right ventricular function. Is continuous wave Doppler over tricuspid incompetence. The peak tricuspid regurg velocity is 3.3 meter per second, and the peak tricuspid regurg gradient is 41 millimeter mercury. IVC is borderline dilated or upper normal 2.2 centimeter, but it collapses more than 50%, denoting proper or normal right atrial filling pressure. Stress echo. As currently practiced with the aid of digital acquisition and storage of relevant images, stress echocardiography is both sensitive and specific for detecting inducible myocardial ischemia in patients with intermediate to high pretested probability of coronary artery disease. Compared with standard treadmill exercise testing, stress echo is of significant additive clinical value for detecting and localizing myocardial ischemia. Stress echocardiography is also recommended when standard exercise testing is likely to be non-diagnostic. Examples include conditions likely to reduce validity of ST segment analysis, such as the presence of resting STT wave changes, left bundle branch block, ventricular paced rhythm, left ventricular hypertrophy or strain, or digitalis treatment. The sensitivity and the specificity of stress echo for detection of coronary artery disease is approximately 80%. Studies suggest that stress echo has a slightly lower sensitivity but better specificity compared to nuclear perfusion stress testing. As with other non-invasive methods, sensitivity of stress echo is higher in patients with multi-vessel disease than in those with one-vessel disease, in those with prior infarction, and those with more than 70% stenosis compared with those with more moderate lesions. The risk of a false positive result is increased in the presence of abnormal septal motion due to left bundle branch block, hypertensive response to exercise, while low workload beta blocker use, prolonged delay in post-stress image acquisition increase the risk of false negative result. A variety of methods can be used to induce stress exercise, either treadmill or upright or supine bicycle, and the pharmacological techniques using either adrenergic, stimulating, or vasodilator agents are often used. Treadmill stress echo may have lowered sensitivity if there is significant delay from the end of exercise to the acquisition of post-exercise images. Sensitivity can also be diminished if all myocardial signals are not adequately visualized. When a non-cardiac limitation precludes adequate exercise testing, pharmacological stress echo is an appropriate alternative. Adrenergic stimulating agents increase myocardial oxygen demand by increasing contractility, blood pressure, and heart rate. They can be given in graded doses to titrate myocardial workload in a manner to standard exercise testing. Vasodilator agents, in contrast, cause heterogeneous myocardial perfusion, which in some patients is sufficient to cause functional myocardial ischemia. Indeed, comparative studies have suggested somewhat lower sensitivity for stress echo using adenosine compared with dobutamine. A negative stress echo is associated with a rate of myocardial infarction or cardiac death similar to age-matched control less than 1% a year, suggesting that additional testing and intervention is unnecessary. Similarly, among patients with non-coronary artery disease, including prior revascularization and abnormal stress echo, is independently associated with a twofold greater risk of adverse outcome. This is a comparison between treadmill semi-supine exercise testing and dobutamine stress echo. The treadmill stress echo is more physiological. However, a disadvantage allow image only in the pre and post exercise, while the semi-supine allow image during each stage of an exercise protocol, both at lower workload and at peak exercise. Disadvantage, patient adaptation. The treadmill is widely available and the patients are more acquainted with treadmill stress test than cycling. And one disadvantage for a cycling stress echo is lower expected maximal oxygen consumption. The vitamin echo allow for assessment in patients unable to exercise, allow for imaging at each stage of the vitamin infusion, both low and high dose. However, no data on functional capacity or exercise performance, risk of atrial and ventricular arrhythmias. Regardless of the stress modality, interpretation of the echocardiographic imaging is based on assessment with excursion and thickening of each myocardial segment at rest and with stress, along with changes in left ventricular ejection fraction and the left ventricular size with stress. Based on segmental wall motion at rest and with stress, each segment can be classified as normal, ischemic, infarcted, or viable. Using the 17-segment models, the wall motion score index is one method to quantify the global ventricular burden of ischemia and or infarction. Segments are scored as 1 for normal, or hyperkinetic, 2 for hypokinetic, 3 for akinetic, 4 for dyskinetic at rest and at stress. The wall motion score index, as we discussed previously, is calculated as a sum of segmental score divided by the number of visualized segments. Increase in left ventricular volume with stress is a high-risk finding in this context associated with multi-vessel ischemia. Of note, increase in left ventricular size is not necessarily an abnormal finding with supine cycle ergometry, given the associated preload recruitment. Image interpretation of stress echo for ischemia assessment. Normal, the myocardial segments are normal contraction, and the thickening is 30 to 50%. This is normal kinesia. And with stress, it becomes hyperkinetic, means thickening more than 50%. The ischemic response, either the patient at rest has the segment at rest is normokinetic, and with stress it worsens to hypokinetic, akinetic, or dyskinetic. This worsening with stress is an ischemic response, whether the baseline was normal or hypokinetic, that becomes akinetic or dyskinetic. Infarction, the segment at rest, either hypokinetic, akinetic, or dyskinetic, and no change in the endocardial excursion or myocardial thickening with stress. Improvement with stress from akinesia to hypokinesia or normal, it goes with a viable myocardium. An ischemic response characterized by worsening contractility of at least two contiguous segments. Moderate to severe ischemia is considered present when 3 or more newly dysfunctional segments are observed. An example of treadmill stress echo demonstrating an inducible or motion abnormality involving the mid and apical anterior segments. Can here appreciate the rest in the stool and at rest. This is the end stool at the apical four-chamber view, and this is the end stool here, but with stress. We can appreciate here the apical septum is not the endocardial excursion, and shortening is much evident than at rest. Also as the anterior wall. And this is an example of left ventricular dilatation with stress. Here, the left ventricle at stress appear of almost dilated, and the contractility and the left ventricular cavity and end stool is almost similar to that at end diastole. Assessment of viability. The presence of myocardial viability is suggested by an improvement of function in at least two segments during the vitamin infusion, whereas no improvement in contractility suggests non-viable myocardium. The biphasic response is characterized by early improvement in contractility at low dose vitamin, typically at 5 to 20 mic per kg per minute, which is then worsened with high dose vitamin, typically 30 to 40 mic per kg per minute, and suggests both viability and ischemia. Improvement in contractility at low dose vitamin is more sensitive pattern for viability, whereas the biphasic response is the most specific and the most predictive of functional improvement with revascularization. Similar to ischemic evaluation, when compared to nuclear imaging assessment of viability, the vitamin stress echo demonstrate lower sensitivity but higher specificity. Older data suggests a sensitivity and specificity of 75 to 90% to predict left ventricular functional recovery with revascularization. Poor image quality, concomitant use of beta blocker, and variable inter-observer agreement, particularly in the face of several resting dysfunctional myocardial segments, are the main limitation of stress echo. Image interpretation of the vitamin stress echo for viability of assessment. Improvement of the myocardial segment systolic function at low dose vitamin, either it becomes worsened with high dose vitamin or continue to improve further with high dose vitamin is called viable. However, this biphasic response is more specific for viability, and it predicts much recovery of left ventricular function after revascularization. While at rest, if the segment is abnormal kinesis and no change with low dose vitamin, this is not viable. If it is abnormal and it becomes further worsened with low-dose vitamin, it means ischemia. Emerging echocardiographic approaches to the assessment of ischemia and viability. Considerable interest has focused on the use of echo contrast for evaluation of myocardial perfusion, 2D spigot tracking-based assessment of strain to quantify segmental left ventricular deformation at rest and with stress, 3D imaging approaches. Although all of these holds promise, none have matured to the point of clinical implementation at this time and are not recommended by current guidelines. Here, a clinical case number 7 show the incremental diagnostic value of 2D spigot tracking to conventional dopamine stress echo in predicting significant coronary artery stenosis. 40-year-old male patient, chronic heavy smoker, not non-diabetic or hypertensive, positive family history of premature coronary artery disease, complaining of chest discomfort on ordinary effort, ECG, sinus rhythm with no significant ST or T wave changes, exercise, treadmill ECG was equivocal, conventional dopamine stress echo with offline 2D spigot tracking analysis for longitudinal systolic strain, both at rest and at peak stress was done. This is the resting apical four-chamber view. You can appreciate there is no significant wall motion abnormalities at rest. Here's at peak stress. As we mentioned before, and for proper acquisition for 2D spigot tracking, we have to obtain the 3 apical views, apical 4, apical 2, and apical 3 chamber views in a proper way with avoiding foreshortening with clear delineation of the endocardium as much as possible. And the frame rate is adjusted to around 80, 60 to 80 by adjusting the sector width and by adjusting the depth and gain. Automatically, we set points as a mitral annulus, 2 points as a mitral annuli, and a point as the apex, and the software automatically track the region of interest. And if it is there is mal-tracking, we can adjust it manually. Then the software automatically runs the strain curves for each segment. Here we got 2-chamber view resting at peak stress. No wall motion abnormalities could be detected either at rest or at wall motion abnormalities. We can here appreciate the hyperkinetic response to the vitamin. So baseline, we get 3-chamber view and a peak stress. The bullseye mapping, we can appreciate here the GLS at rest was -21%. This is good shortening, and this is bullseye mapping. Almost all regional strain are good values. Here at peak stress, the GLS reduced to -19. This is mean this shortening. The more the negative value, this means more shortening. So -21 is much better than -19. And we can appreciate here the significant reduction in the longitudinal systolic strain values in the territory of the LAD in the basal and the mid anterior septum specifically, and also at the basal or mid anterior wall. Here is the coronary angiography. We can appreciate here this significant lesion at the mid LAD. Thank you. It's the end of our presentation, and I hope it is good for everybody, and good night.